Okay, thank you so much everyone for joining us again. This is our 7th edition for this year, the ACNS WIN Women's Webinar. We're very happy as usual to have our patron, Professor 𝒂𝒂𝒏𝒂𝒄𝒂, coming here today and gracing this webinar. Today we will also have our chair will be Associate Professor, Professor Hidehito Kimura from Department of Neurosurgery, Kobe University, Graduate School of Medicine, Kobe, Japan. And joining us today, we have two discussants, Professor Shiro Horisawa, who is actually Department of Neurosurgery, Stereotactic and Functional Neurosurgery from Tokyo Women Medical University, and Professor Masamichi Kurosaki from Department of Brain and Neuroscience, Faculty of Medicine, Tottori University of Japan. So without further time, I will just invite now our first speaker, Professor and Chairman of Department of Neurosurgery, Second Affiliated Hospital, Soochow University, Suzhou, China, Professor King Lan. Professor?
Thank you very much. I will share my screen.
So, Doctor, you are replaced of Dr. Queen Lan?
Well, I replaced him. He was in surgery now.
Okay, can you just introduce yourself?
Okay. Can I have your name? Can we have a name, please? Doctor? Maybe Dr. Two?
Can you introduce yourself?
There is some problem with the internet, I think.
Yeah, because he's sharing his screen, but the screen has not come on.
It is stuck.
Yeah, hang.
I think it's
He's
not visible. There is some issues with his internet.
Maybe we can invite Professor Kimura.
Yeah.
Okay,
yeah.
Kimura.
No, he's still not there. Okay, we start off with Professor Kimura first.
Next speaker.
Yeah, we start with our next speaker, Professor Yukiro Kimura. She's the neurosurgery staff of Department of Neurosurgery, National Center Hospital, National Center of Neurology and Psychiatry, Tokyo, Japan. Today, she will be presenting to us the challenging of deep brain stimulation for refractory Tourette syndrome in Japan. Professor Kimura, are you ready?
Yes, just a moment.
Yeah, you can start sharing your screen when you're ready.
Let me check my screen.
There is a green button. You have to press that green button which says share screen.
Just a moment.
Just below you see your photo, there is a small green button, share screen.
Yes, now I'm doing that. Just a moment.
Okay,
take your time. It's okay.
Okay.
Yeah.
Very nice.
Yes. So, thank you very much. It is my great honor to be here today to speak with you about our challenges. Today, I'd like to discuss the possibilities of deep brain stimulation for treating Tourette syndrome. So, DBS produces electrical impulses that affect brain activity to treat certain medical conditions. Now, DBS is approved for Parkinson's disease, essential tremor, dystonia, and epilepsy. Also, other psychiatric disorders could potentially be treated by DBS, such as Tourette syndrome, OCD, depression, and dementia. And in this condition, we have been working on DBS for Tourette syndrome for more than over 10 years. Tourette syndrome is defined and diagnosed as having these characteristics. For instance, more than 40 ticks and more than 1 year duration, and start before 18 years old, and no history of substance abuse or other medical conditions. Severe motor tics may cause life-threatening injuries. For instance, these are images of cervical cord injury caused by head hitting ticks. You see? And also, vocal tics prevent patients from school and work, worsening their quality of life. Since Dr. Christopher Waller reported the world's first use of DBS for Tourette syndrome in 1999, there have been several reports, including randomized controlled trials. Despite positive results from them, the evidence for efficacy of DBS has been regarded as insufficient by consensus guideline for tic disorder. This is because it is supposed there are several problems concerning DBS. Although the effectiveness of DBS has been established worldwide, the long efficacy is still unclear. Another concern is that there are few targets like central median thalamus, anterior GPI, or nucleus accumbens, or anterior lobe of internal capsule. So many targets area of the brain that can affect Tourette with DBS. So we haven't identified the best target area yet. And one of the biggest problem is ethics, because Tourette is considered as a psychiatric disorder. Some strongly oppose surgery for it. So DBS for neuropsychiatric disease such as Tourette, depression, and OCD is not approved in most countries, including Japan. So the possibility of, and also the possibility of spontaneous remission also must be taken into account prior to surgery. Therefore, indication for DBS must be restricted and well evaluated. These are the indications that we are taking into account. So ages should be 18 years or older, and severity is one of the most important things when we apply DBS for the patient. Now, we will report here the short and long-term outcome of DBS for Tourette syndrome, including efficacy evaluated 𝑦𝒐𝒑𝒆𝒔. This is a popular evaluation of Yale Global Tic Severity Scale, 𝑦𝒐𝒑𝒆, and adverse events and status of current DBS patients. Here you can see some of our patients' data. At this time, 39 patients have had DBS for a year or more. The graph shows 𝑦𝒐𝒑𝒆 motor and phonetic score and impairment over 5 years. The maximum score of 𝑦𝒐𝒑𝒆 for tics are 25 and 50 for impairment. So motor tics improved from 20.2 before DBS to 10.8 a year after, and phonic tics improved from 19.6 before to 9.6 1 year later. And also in 3 years after DBS, 𝑦𝒐𝒑𝒆 improved to 7.5 and 8.1 in 23 patients. And in 5 years or more, a mean of 𝑦𝒐𝒑𝒆 were 7.7 and 7.0 phonic in 12 patients. So I'd like to show you the change in a patient's drawings that indicate how her symptoms have improved. Before the surgery, she was unable to control her movements and could no longer draw or even hold a pencil. So she was unable to draw illustrations that she loved due to disturbing tics. However, here's a key change she gave me after a year of DBS, so you can see how much her symptoms improved. And concerning adverse events, this is a graph showing complications of DBS. The frequency of device infection tends to be higher for Tourette syndrome patient than for other conditions like Parkinson's disease. So infection rate is relatively higher. And this is easier and this is earlier. The most likely side effect due to stimulation. So most are transient, but and improve with adjustment of DBS output. So DBS is supposed to be permanent in Parkinson's disease and other movement disorders, but this is not the case in Tourette's. Surprisingly, only 77% have continued DBS all the way to the present time indefinitely. Not only are some people unable to continue DBS due to infection, but also some people have voluntarily stopped DBS due to the burden of it. The burden includes charging bodily and maintenance issues. And also, the symptoms can recur when the treatment is stopped. There are 3 patients who have remained symptom-free. So, let me show you a comparison between the effectiveness of the treatment with other reports. The improvement shown in previous reports appear to be almost the same as our results. And curiously, there are cases that DBS is withdrawn for various reasons and symptoms do not worsen. Please take a look at case 1 with black line. DBS worked well and his symptoms were almost gone in 3 years. But 7 years after DBS, the device infection occurred, and at that time, symptoms did not appear. So, prior to device removal, we turn off the DBS, but the symptom didn't reoccur. And after the DBS, and he has remained symptom-free after DBS removal. So you can see this is a DBS off, but he remains symptom-free. On the other hand, case 2, shown by the yellow line, the patient's post-operative symptom fluctuated, but improved significantly. So she strongly requested stopping DBS due to the burden of bodily management. Therefore, DBS was turned off 9 years after DBS. At that time, her symptoms worsened. So, DBS was switched on again to control her symptom. So this may be due to the natural cause of the disease. However, patients stopped DBS after a dramatic reduction in symptom with DBS. This suggests that DBS may also cause long-term changes and may normalize the striate thalamus cortical circuits. And the risks of adverse infection had seemed relatively high in Tourette cases compared with other movement disorders. We supposed the reason that Tourette patients require pulse generator replacement many times is not only due to high voltage consumption, but also that they are so young and have to live with DBS for the rest of their long lives. And Martino suggests these three main causes of the higher infection rate among Tourette DBS patients are large and frequent physical motion and multiple pulse generator replacement and autoimmune problems with Tourette patients. Now, effect of DBS have continued for more than 5 years in our observations and may continue in ages. And as I mentioned, we should consider the complications such as infections and the possibility of spontaneous remission. The decision to apply DBS should be made carefully due to the risks and unknown progress. However, it has had significant benefits for a majority of patients. Now we are working to expand the indications for DBS in Japan while addressing ethical issues, and there is a good possibility of extending the indication of DBS not only for Tourette's syndrome but also OCD. So our goal is to ensure that suffering patients have access to the best treatment. Thank you for your listening to my presentation.
Thank you so much, Prof. Kimura. I think now we will just allow our chair, Prof. Hidehito Kimura. I think you can take over for the discussion since you're the chair today. Thank you very much.
Thank you, Dr. Sharon. So thank you, Dr. Kimura. Nice presentation. So I have several questions. Maybe some audience may have some questions. So because before asking them, I just want to ask you about several questions. So my first question is, this is basically a fundamental question maybe. So how about Tourette syndrome is a permanent disease or something is a patient suffering in the younger age? So in my opinion, the Tourette syndrome may the symptom may be decreased in the elderly adolescent area, or maybe over the 20 years of age years old, the symptom may be naturally improved. Something it may happen. So my first question is the indication of this surgery in a younger patient. Thank you. How about the indication of this surgery?
Well, we usually restrict the age over 18 years old because younger generation may get remission or get better when they become adult or become adolescent ages. So once in United States, indication of Tourette's DBS was more than older than 25 years old because they considered younger generation may get better before 20 or 25. But now we are thinking that we must conduct DBS much younger than 25. Now our indication is 18 because of course we have to take take into account the natural remission, but they cannot go work, they cannot go school due to the tics, so they may lose their nice lifetime. So But of course, as you mentioned it, how to say, Tourette syndrome can be treated naturally, or the symptom is always fluctuated, so it is difficult to decide when is the best timing of DBS.
So you mean after the patients the over 18 years old, the patient have a chance to receive this surgery?
Yes.
Okay. Well, in United States, over the 25 years old.
It used to be, but now I think,
much
I
younger.
think I think probably 18 is how to say, global standard age
I see.
for Tourette DBS. Yes.
Yeah. So my second question is to perform the DBS for the patient with Tourette syndrome is already had a consensus, international consensus to receive this surgery, or I think so I just want to confirm about the target of this DBS for the Tourette syndrome. Is some different to the target of the Parkinson disease or something like that? I just want to confirm about it again. Thank you.
Well, yes, as I mentioned it in my presentation, there are a lot of target for DBS of Tourette syndrome, but we conduct DBS for central median thalamus, DBS for Tourette syndrome. So it's different from Parkinson disease, of course. And well, and unfortunately, in Japan, we are not allowed to doing DBS for Tourette's within health insurance. So we conducted as a, how to say, as a research, but it is covered with health insurance as involuntary movement disorder. I mean, so so it's very how to say, not so clear. So for instance, in United States, DBS for Tourette's is conducted as a HDE, humanitarian device exemption. So they can conduct as a HDE in United States, but in Japan, there was some objection against psychiatric disorder surgery, surgery for psychiatric disorder. So we conducted as if or as movement disorder.
Yeah.
Within health insurance system.
Yeah, not yet covered right now. So
yes. Not it's not covered correctly. Yes.
Yeah. Thank you. So my third question is, you mentioned about the post-operative infection rate is a little bit higher than the other DBS patient. So if such a complication considered by such a consideration complication as just thalamotomy or something like that, not stimulation, just perform better, maybe some kind of optional treatment, not stimulation, but so in just a thalamotomy, you need to insert every other instrument devices into the patient body. You don't need to perform any additional surgery if you do so. Why don't you choose that thalamotomy surgery to the patient? Thank you.
Yes. Absolutely. Yeah. How to say, so thalamotomy is one of the option of Tourette syndrome surgery because probably thalamotomy is how to say, less infection rate than DBS, of course. But well, on the other hand, concerning ethical problems, well, thalamotomy is how to say, permanent permanent how to say treatment and surgery. So and also yeah, there was some report about solomotomy for Tourette syndrome, and yeah, it seems to be effective, but as an ethical problem, we think DBS is better to be considered as good for how to say really adjustable and not so injured way to treat for them.
I see.
Mm.
Thank you. So I just want to open the discussion for the audience. So I just want to ask first Professor Horisawa, do you have some comment to this presentation? Thank you.
Can you hear me?
Yes.
Yes.
Okay. Thank you for your great presentation, Dr. Kimura. I really enjoyed your presentation. And I'm really interested in the improvement of a comorbid psychiatric symptoms in OCD by your surgery. It's relatively large cohort, 39 patients. It's very large study in terms of a Tourette syndrome DBS. So I really appreciate it. And the Tourette syndrome usually has a OCD or depression or anxiety or such kind of a comorbid psychiatric symptoms. How was your results of the anterior paradigm DBS for, this OCD or anxiety, or it's very, very important for us?
Yes, thank you very much. It's a big issue about Tourette syndrome. Yes. Actually, yeah, I think or I feel, how to say, OCD or anxiety will be better after Tourette syndrome. How to say, with getting better with TIC severity score. So yeah, it seems parallel to be better. But on the other hand, in my how to say, in my opinion, well, some still have a problem with obsessive compulsive disorder, even though he get better concerning Tourette or tic severity scale. So I'm not sure who can be treated Tourette and OCD together, but some still remains OCD symptoms yet. So, and as a previous report, some reports say Tourette with OCD can be treated with central median DBS, but in my opinion, some are getting better, but some are not so how to say, not so good. So it's still under how to say, consideration of us.
Yes. I think that is a very good point. So where to place the electrode? So we have so many targets: anterior paradigm, subthalamic nucleus, or central median, or the pyrosamic tract, the field of rail. So, but I think that in terms of treating a comorbid psychiatric symptoms, so SDN or field of rail or central median looks better than the anterior paradigm. But I'm not sure. We have a very limited cases of a Tourette syndrome by the lesioning surgery at the field of rail. So that's a very interesting point of where to place the electrode, where the best in the Tourette syndrome. So I really appreciate your big studies, and so wait for your good long-term outcome of a psychiatric.
Yes,
Yeah.
Thank you very much. Yeah, we have to follow the comorbidity also. Thank you.
Yeah, thank you. Thank you.
Thank you, Dr. Horisawa. So I just think about how many targets do you have for the patient with the Tourette syndrome? So in the talking from Dr. Horisawa, so you have indicated so many targets of the Tourette syndrome. So what is the good point? The good maybe the most optimal point target for the Tourette syndrome other than the Parkinson disease. I can't understand the differences between two diseases, the target, how to choose, you choose, yeah. Yeah, maybe you should change the patient's symptom. Maybe, but may target symptom, their cognitive function or something, psychiatric symptom. Maybe target should be changed that due to the patient condition. So, what is the main target of your treated target for the patient with a Tourette syndrome? So let's just make sure about it. So thank you.
Well, in our hospital, I only have experience of DBS for Tourette in central median thalamus, so I haven't had any experience of the other targets. But well, as you mentioned, maybe we can choose, or we have to choose the target, depends on patient symptom. So, well, but probably the biggest RCT is conducted DBS for central median or anterior lobe of the anterior lobe of internal capsule or nucleus accumbens. So, well, probably we have to wait for other data of targets. And yeah, someday we may choose the targets. Depends on patients.
Thank you.
Thank you very much.
Thank you. Is there any comment, question from the audience? Thank you. Dr. Shalom, do you have something?
I think
Okay.
just was finding interesting, Kimura. Is there any reason why the infection rate was higher in these patients?
Well, I'm not sure about, well, as I mentioned it, well, they have very large ticks and movement with ticks. So, and also they are relatively young than Parkinson's disease patients. So they are so active. And yeah, they worked outside. So they move with sports. So in that case, yeah, Tourette's patients may increase the infection rate, and of course, also how to say, DBS bodily consumption is very frequently. So they need. For instance, once a year replacement of battery. So yeah, it may increase the risks of infection. So yeah, almost all patients use rechargeable battery, but well, they still have problem with infection. So
And you have
it's a big.
And you had one patient that actually you removed and didn't have any symptoms. Do you think that it actually happened like indirectly you sort of lesioned that area and sort of cured that person maybe?
Yes, yeah. It's very, how to say, surprisingly cases. So even though we stopped DBS, the symptom did not appear again. So, well, so it may be because of natural history of the Tourette syndrome, because Tourette can be getting better with their ages. But well, I'm not sure. So, yeah, it's not possible if this is a case of Parkinson's disease. But well, I guess Tourette syndrome can be how to say, fluctuating, or something they have much more, how to say, adjusting network of the brain. So probably DBS can affect nice for their symptom and adjust something. And yeah, after that, the symptom gone away. Yeah, that's my opinion. Thank you very much.
Thank you. Thank you.
Is there any more questions, or shall we move on with our next presenter? Okay. Prof. Kato, do you want to ask any questions, or shall I just move on?
I admire Dr. Kimura, that your work is very, very nice. I think. So please extend the experience to more and more the teachers.
Yeah, thank you very much.
For next time. Thank you very much.
Thank you very much.
Thank you.
Are you ready, Prof. Kinglan? Are you ready?
Okay, I'm ready. Okay. I'm sorry, I have some mistake of my computer just now.
Okay, no problem. Okay.
I share my screen.
Can you introduce yourself, please? You're not Kindan.
I'm one of the member of the team of Qinglan.
And can your name, please? You can get to know you a bit. Oh, okay, Sincho.
Okay, can you hear me?
Yes.
Yes.
Yeah, my presentation.
Your name is Chin Tzu. It's okay.
Yeah, yeah. Oh, yes. Okay, good afternoon, professors. And I'm very glad to have this opportunity to introduce the work of the neurosurgical team led by Professor Qinglan in microsurgical clipping with multiple intracranial aneurysms via the keyhole approach. And since the advent of keyhole microsurgical approach in neurosurgery, these minimally invasive procedures have become widely used in the treatment of anterior and posterior circulation aneurysms, and have been increasingly used in the treatment of complex aneurysms, such as ruptured aneurysms and giant aneurysms. And the use of hybrid surgical suite combined with endovascular therapy improves the minimally invasive treatment of complex aneurysms. Although the incidence of multiple intracranial aneurysms is as high as 15 to 35%, the application of a keyhole approach in the clipping of multiple intracranial aneurysms has seldom been discussed. And here, I will respectively analyze the 80 consecutive patients with multiple intracranial aneurysms treated with the keyhole approach. Methods. The inclusion criteria was 2 or more aneurysms confirmed by CTA or DSA, and signed informed consent for treatment of the patient's condition by keyhole surgery from the patient or guardian. Preoperative plan to clip 2 or more aneurysms, followed by intraoperative exploration, and the determination of the treatment plan by doctors in the cerebral vascular disease group, who skilled in both the keyhole microsurgical clipping and endovascular coiling, on the basis of the patient's condition and the unique nature of aneurysms, as well as the patient's or family's preference between the 2 treatments after being informed on the pros and cons of each. The exclusive criteria was including advanced age, severe underlying diseases, or grade 5 on health classification, intracranial hypertension, or the possibility of decompressive craniectomy, and lack of follow-up for more than 6 months after surgery. Totally, 80 patients was enrolled, accounting for 16% of the 501 patients who underwent a keyhole clipping during the study period. There was 25 males and 55 females, aged 36 to 73 years, and 13 patients with unruptured aneurysms, 67 with ruptured aneurysm, totally 198 aneurysms, and 36 patients underwent early surgery, 27 underwent midterm surgery, 4 underwent late surgery, and the rest underwent elective surgery. The preoperative Hunt-Hess classification was grade 0 for 14 patients, grade 1 4 patients, grade 2 33 patients, grade 3 24 patients, grade 4 5 patients, and all diagnosis was confirmed by CT, DTF, or DSA. According to the CT image of patients obtained at the time of admission, the Fisher classification of SH was grade 1 in 15 patients, grade 2 29 patients, grade 3 21 patients, grade 4 15 patients. 42 patients had the bilateral aneurysms, and 38 had the bilateral aneurysms. And after general anesthesia, catheter was placed in the lumbar system for patients with ruptured aneurysms. During craniectomy, intravenous infusion of Mannitol was performed rapidly. When the dura mater was opened, the lumbar drainage tube was opened, and 30 to 50 millimeter of CSF was slowly released to lower the intracranial pressure. Under a microscope, the Sylvian Fisher, the lateral internal carotid artery system and the optic chiasm system was dissected sequentially to release the CSF and remove the subarachnoid hemorrhage. After the parent artery was exposed, the neck was dissected and clipped. Finally, intraoperative ICG angiography was performed to confirm the patency of the parent artery and the obliteration of the aneurysm sac. The keyhole approach we used was a supraorbital keyhole approach, pterional keyhole approach, and the interhemispheric keyhole approach. The indication for primary surgery, including the first was with the primary goal of clipping the ruptured aneurysm. The bilateral aneurysm would also be treated on principle. If the operation was affected by a high intracranial pressure, a complex unruptured aneurysm, or a high risk of surgical clipping, the bilateral aneurysm could be left for the later treatment. When clipping of the bilateral ruptured aneurysm could affect the later clipping of the unruptured aneurysm, the unruptured lesion was treated first under the premise of effective control of the parent artery. The contralateral aneurysm should be primarily clipped. After successful clipping of the ruptured aneurysm, combined with the preoperative image findings, the intraoperative intracranial pressure, and the results of a contralateral exploration, whether to use the same approach or a separated contralateral keyhole approach to clip the contralateral aneurysm was decided. For patients with complex aneurysm, multimodal image fusion was performed preoperatively to construct a 3D model for preoperative planning, and when necessary, a 3D cranial cerebral aneurysm model was printed, and simulated surgery was performed to determine the feasibility of the best plan for surgical clipping. Results: 18 patients were treated with the bilateral keyhole approach, and 62 were treated with the unilateral keyhole approach. The supraorbital keyhole approach was used 48 times, and the pterional keyhole approach 45 times, the interhemispheric keyhole approach 3 times, and in all, 170 bilateral aneurysms was clipped. 3 contralateral aneurysms was clipped. 21 aneurysms could not be clipped for the following reason. The first is the exploration of the aneurysm neck was poor due to the influence of the optic nerve, optic tract, internal carotid artery, or the anterior clinoidal process, or because the wide neck of the aneurysm affected the contralateral operation. And the second was the aneurysm was located in the cavernous sinus. The third is the contralateral middle cerebral artery M1 segment was relatively long, and the contralateral middle cerebral artery aneurysm need to be clipped was farther away, or the patient was unwilling due to their physical condition. And after surgery, DSA revealed a slight residual aneurysm in the neck in 2 patients, and a new diagnosed aneurysm in 1 patient. This patient preoperative CTA diagnosis was negative, and 2 new aneurysms after 1 year. There was 3 patients who developed a new aneurysm, and the postoperative complications. 3 patients developed the intracranial infection, and 3 patients received VP shunt for the hydrocephalus. 4 patients experienced the short-term oculomotor nerve paralysis, and 4 patients experienced the systematic cerebral vascular spasm, and 2 patients experienced the intraoperative olfactory nerve injury. Here we illustrated a typical case, and this patient, 51 years old female, and who diagnosed with multiple intracranial aneurysm by physical examination due to dizziness. And the DSA revealed right middle cerebral artery aneurysm, A1, bilateral aneurysm, and the contralateral A1 segment aneurysm, and a very small ACOM aneurysm. And the microsurgical clipping via the right pterional keyhole approach was performed. And after control, the bilateral M1, the tentative clipping was performed to facilitate the MCA aneurysm sac remodeling. And then we use a bent clipper. This is the first clipper. And we release the tentative clipper. And then the second was use a curved clipper. And the next 2 clipper was also the straight clipper. This is the final clipper, is the mini straight clipper. And was the MCA aneurysm was clipped. And then we use a long straight clipper to clip the contralateral A1 segment aneurysm just from the direction behind the bilateral A1. And this is use a mini curve clipper to clip the very small aneurysm over the ACOM artery. And then the last was the straight fenestrated clipper for the bilateral A1 segment aneurysm. And this is the keyhole window we used during the operation. Post-operative angiography revealed the total obliteration over the 4 aneurysms, and the CT perfusion excluded the surgical-related ischemic events. Discussion. The prevalence of intracranial aneurysm in adults is approximately 3%, although the annual rupture rate is low. Once rupture occurs, the mortality and the disability rates are high. According to the ISUIA study, the possibility of aneurysm rupture increases with diameter beyond 7 millimeters. Observation and follow-up can be performed for small unruptured aneurysms. However, the present study revealed that small aneurysms account for 52.2% of the ruptured aneurysms, indicating that it is also important to actively intervene in case of small aneurysm to prevent rupture, especially in case of multiple aneurysms. The chance of a rupture of a small aneurysm can be increased by 10 times, so these aneurysms should be treated early. And due to the minimal invasiveness, endovascular treatment has gradually replaced microsurgical clipping for aneurysms in most cases. Compared with surgery, endovascular treatment is associated with lower mortality and mobility rates, a lower incidence of seizure, and a slightly higher recurrence and rebleeding rates. However, in the case of multiple aneurysms, surgical clipping may still be chosen due to facts such as the cost, the need for surgical removal of intracranial hematoma, or anticoagulated therapy after stenting. The 10-year follow-up results of the two treatment groups are similar, with a better effect of endovascular treatment observed only for posterior circulating aneurysm. And for very small aneurysms, wide-necked aneurysms, complex aneurysm with vascular branches or perforators originated from the neck of the aneurysm, fusiform aneurysm, middle cerebral artery aneurysm, ruptured aneurysms with large intracranial hematomas, and aneurysm with intraluminal thrombi, as well as for patients who cannot be followed up normally. Micro surgical clipping is recommended. And the keyhole surgery is a good choice for intracranial aneurysms clipping. A large systematic review of over 1,000 patients revealed that 97% of the intracranial aneurysms clipped via the pterygoidal keyhole approach was completely clipped. During keyhole surgery for multiple intracranial aneurysms, under the premise of ensuring clipping of the rupture aneurysm, clipping of the explanatory aneurysms is usually a matter of time. And after effective preoperative planning, the clear intraoperative exploration, most contralateral aneurysms can also be clipped simultaneously using the same keyhole approach. The rate of complications after keyhole surgery is comparable to that after conventional craniotomy surgery. And according to the group comparisons, primary surgical clipping of multiple intracranial aneurysms is cost-effective and leads to shorter hospitalization durations, which has great advantages. The preoperative Hunt test grade of patients is closely related to their prognosis, but it does not affect the difficulty of keyhole surgery for patients below Hunt test grade 5. And some patients in this study were diagnosed based on CTA before surgery due to the need of the emergency surgery. DSA is the gold standard for the diagnosis of aneurysm, but still misses some tiny aneurysms. Thus, careful intraoperative observation is important. And in the present study, 2 new aneurysms were found after 1 year of follow-up, which suggests that the importance of the long-term follow-up of patients with multiple aneurysms. And so our conclusion is early keyhole surgery for the multiple intracranial aneurysm is an effective treatment method. In particular, the timely treatment of small aneurysms is highly beneficial. It is also necessary to ensure regular long-term follow-up of patients after surgery for multiple intracranial aneurysms to detect a new aneurysm in the timely manner. That's all. Thank you very much for your attention.
Thank you, Dr. Zhang Qianzhao, right? Yeah, fantastic presentation. So I learned a lot. I enjoyed so much. So I just want to give you some comments first. So contralateral approach for the multiple aneurysm is a good procedure for the patient suffering a multiple aneurysm. You can treat the patient multiple aneurysm simultaneously in one single surgery. It's a good treatment option for the patient. So I do also the same procedure for the contralateral middle cerebral artery aneurysm can be treated through ipsilateral approach. It's a good indication. So do you give us a good some comment to contralateral indication for the contralateral approach middle cerebral artery aneurysm? Do you have some comment? Contralateral.
Yeah. Okay. Thank you. This is a very important issue. And for us, we do the contralateral clipping only the patients with some good indication. And for example, the patient does not have the high intracranial pressure, and the aneurysm we can exploit easily during the surgery. And we also do some anatomical study for the the length of the contralateral M1 segment, we found that too long M1 segment is a contraindication for the contralateral surgery. And another is the projection of the M1 bifurcation aneurysm. Because the posterior projection we can't exploit during the contralateral approach, and we only for the anterior and the down projection aneurysm can be clipped from the contralateral approach. Thank you.
Yeah, I totally agree with your comments. So, and contralateral approach, good indication is a anterior projection and a small sized aneurysm, and a short M1 is a good candidate for the contralateral approach to the 𝑑𝒓𝒐𝒏𝒈. Thank you.
Yeah.
Okay. And my second question is, do you measure the size of the craniotomy intraoperatively? So you mentioned you stress the keyhole approach, keyhole craniotomy for this surgery. So do you calculate the size of the craniotomy intraoperatively?
Yeah. The bone window we always is 2.5 centimeters to 3.0 centimeters. It's enough because we found the patient with the Hunter's classification below grade 5. If we use the infusion of the monitor, or we level up the position of the head, and just the lumbar drainage, we can control the intracranial pressure very well. So a very small craniotomy is enough. But for the patient with the possibility of craniectomy, we do not perform the keyhole approach. It's a disaster.
I see. So, and is there any question from the audience? Thank you.
Yes, it's Idiska. So thank you very much, Dr. Tu.
Thank you.
Oh, thank you so much. Maybe, hopefully, maybe we want to see Dr. Quinlan. Still, is he doing the surgery?
Yeah.
Okay.
The surgery.
Yes, congratulations, very good presentation. So, but in your report, maybe that you mentioned about some recurrence or remnant neck cases. So how you can confirm the complete quickness? Do you use ICG or endoscope or some meter or whatever? How you can confirm the completeness?
Endoscope and ACG we perform the routinely. For some patients, because recent years we have the hybrid operation room. So the patient recently we performed the surgery in hybrid operation room, and after clipping we performed the angiography from the femoral artery. So I think this will be the gold standard for the confirmation of total clipping.
Okay. So what about the usual surgical time, average surgical time?
Contralateral approach, the surgical time was a little longer, a little longer compared with the bilateral side craniectomy, but it was also shorter than the I'm sorry, it was shorter than bilateral craniectomy. Yeah.
Maybe
I
1 hour.
think
The average of the operation time. 1 hour
hours
or 2 hours?
Don't need 1 hour. I think the half an hour is enough. After we manage the ipsilateral aneurysms, and we performed the contralateral aneurysm clipping is in below half an hour. Yeah.
That means 30 minutes.
Yeah.
Yes. and also, what about the maybe the days? Is it day surgery sometimes?
We perform the emergency operation because if we encounter the ruptured aneurysms when the patient admission to our department, we will perform the surgery as rapidly as possible.
Okay. Thank you, Professor.
Thank you, Professor.
So many questions. So many questions.
Yeah, please.
Yeah, thank you, Sensei, for this wonderful lecture. We learned a lot. I just wanted to know two things: whether do you use any special type of instruments to reach the other side of the brain? Like sometimes some people advocated to use the bayoneted type of instruments so that your vision is not blocked. And second question is, how many cases of intraoperative rupture did you encounter in your series?
I'm sorry, I beg your pardon.
No, do you use some bayoneted type of instruments or normal instruments? Can you hear me?
Do you use special instrument, especially
to
the
reach the other side of the brain? Are straight instruments or bayoneted type?
Okay. I see. The instruments we used mainly was only the suction and the clip application and the dissections, and in the routine operation we use the 22 millimeters long such as the suction and the dissections, but in the contralateral side we use 27 millimeters long instruments. That's enough because the more long we encounter that the manipulation was unsteady.
How many cases of intraoperative rupture did you have? Any cases of intraoperative rupture?
Account for 10%. I think 10%. But we before our craniotomy, and we prepare for the 2 sections, and if we encounter the intraoperative rupture, and one section was for the removal of the clot, and the another was we used it as the dissections and to rapidly dissect the neck of the aneurysm, then we clip it.
Thank you.
Thank you, Professor.
Thank you. Good comment. Thank you. Dr. Hai Pham. Yeah. Thank you.
Good afternoon, everybody. My name is Huy Pham from Vietnam. In the report that you have the contralateral aneurysm, the MCA, also P-common anterior choroidal artery, as I remember. So, what type of contralateral approach that you employ to reach those aneurysm?
Yeah, well, this is we always for the contralateral aneurysm we prefer to use the supraorbital approach, because we have done the anatomical study. We found that the supraorbital approach to reach the contralateral M1 bifurcation was shorter than the via the pterygoidal keyhole approach. But the patient illustrated just now, we use the pterygoidal keyhole approach because this patient was an older lady, and her eyebrow was not so good. We consideration of the domestic problem, so we selected the pterygoidal keyhole approach.
Yeah, thank you.
No, thank you.
Thank you.
Good comment.
Dr. Tzu, why the patients? Why you do not use a supraorbital approach?
The illustrated patient.
Yeah, you said if the patient, usually you do not use supraorbital. Why?
Yeah, because the anatomical study we performed just to show that that's the length from the bone window to the contralateral M1 bifurcation is shorter than that from the pterygoidal keyhole approach bone window to the contralateral M1 bifurcation. So we prefer to perform the supraorbital keyhole approach.
Thank you.
Yeah,
Thank you, Professor.
Yeah. Yeah, but the important point you mentioned about is several kind of good comment. So the rapid approach, the indication is maybe limited case, I think. So of course, unruptured case, of course, to cope with the intraoperative ruptures adequately. So but a good comment, but good surgical procedure for the contralateral approach in some patients. Thank you. I totally agree with your comment. Yeah.
Thank you.
Thank you. Is there any other comment?
So, Professor Horisawa, do you want to comment?
No, thank you. I really enjoyed it. Thank you so much.
Okay, so if we have no more comments, thank you so much for your presentation today. Yes, thank you. We can go on to our next speaker, Professor Marutu Tamura. Are you ready? Yeah, Professor Manubu Tamura is going to present to us the role of pre- and intersurgical management of gliomas located near the function area. So you can start. Okay.
Thank you. Thank you so much.
We are seeing the Zoom, Sensei.
The Zoom?
You
Oh,
can-
sorry.
Once you click, you will see many options. Just click on one screen with the PowerPoint.
Okay.
Please open the PowerPoint and then click share.
Yes. Oh, sorry. Can
You can close the calendar. Okay.
Yes. Very sorry. Okay. Could you hear me?
Yes.
Yes. Yes. Okay. Yes. Thank you. My name is Manabu Tamura, and good evening, everyone. I greatly thank to give an opportunity for my talk by chairpersons and all organizers of the ACNS Wing meeting. My name is I'm from Tokyo Women's Medical University. I would like to present my presentation and share with you. Okay. Here is today's agenda. Firstly, I introduce our team, and secondly, I explain our preoperative and then intraoperative management of intracranial gliomas. In glioma surgery in TWMU, in our university, we have developed SCOT in 3 stages. And now we experienced over 2,200 MRI-guided navigations and 560 awake surgeries. Since 2000s, we have clinically operated in an intraoperative magnetic resonance imaging guided navigation, like craniotomy and EMS. And since 2000, from 2014, we developed Smart Cyber Operating Theater, SCOT, and continuously we developed Hyper SCOT as clinical research from 2019. Now, in our Smart Cyber Operating Theater, we call SCOT, we utilize surgical support using advanced medical devices for which one the open MRI to confirm brain shift and residual tumor as followed, and also surgical navigation system to visualize tumor and surgical instruments, and 4K 3D video microscope, and patient monitoring like this. So we turn to pre-operative management about 𝒊𝒏𝒈 labeling using 𝑏𝒂𝒂𝒏𝒈. We have studied about 𝒊𝒏𝒈 auto labeling from MRI-TI weighted image using 𝑏𝒂𝒂 free software that represent brain 𝒊𝒏𝒈 and 𝒌𝒑 in 3D, compared with normal brain and auto-label patient's brain as to object-based morphometry theory. We get at all the patient MRI based on the normal brains like this. So we show the case related to the correspondence. First, this case is to say the corresponding case between pre-operative labeling like A, like this, and in brain visa, and real central sulcus is confirmed with SVP in operation room like this. So it's a corresponding case. So major case is a corresponding case. And turn to the simulation using the pre-operative T1 MRI. In this right parietal region, pre and post-operative simulation is performed in 3D view, like this. This. So here is pre-surgical simulation for post-tumor removal. And this 3D view is quite similar to real view after tumor removal. So as to motor function, DTI tractography was not reliable for upper limb, which means false negative. DTI FA color map and navigated TMS compensated the tractography, and finally we confirmed with SEP and MEP monitoring and direct manual muscle test in operation room to avoid complication. In DTI tracking with ROI of brain stem, only CST near lower limb was described and not visualized for upper limb fibers, which means false negative. In the other hand, preoperative navigated TMS revealed monitoring APV muscle contraction as a preoperative motor function area as upper limb motor area. Finally, we could, in this case, confirm the real motor function with direct response by electrical stimulation on cortex and direct muscle contraction. Here the operation records. Now, in the literature, we found various activations in language tasks on fMRI as follows, like A, story listening, B, silent reading, C, silent word generation, D, sentence repetition. We obtained more localized activation with picture sentence matching tasks than the other tasks like this. So this slide shows final confirmation in our craniotomy. Firstly, cortical mapping routinely. Sorry, in Japanese.
せーの、はい。犬。はい。せーの、はい。うさぎ。
Picture
なんか
mapping test.
なんか同じのが出てますよ。いいよ、同じの出てて。いいのよ。バレました。
And secondly, detecting language-related area for surgeons' decision making.
で、これからちょっと手術始めるので、ちょっとね、厳しい感
The
じ。
discussion with between patients and the operator.
塩の上いやー、
Serious
トナカイは
confirmation.
何これ トナカイ
Operator decided to operate or remove the
どう
tumor.
するか、いろいろやりながら考えるから。
でもリハビリで残るなら取ってください。
了解。
So, finally, monitoring
ツボじゃなくて
language function removal. The patient is speaking intraoperative awake craniotomy.
松葉
No, tumor removal.
わからない。
So, intraoperative management about combination between we show the preoperative DTI and the intraoperative MRI. So, this is a new developed system in which an 𝒂𝒂𝒏 as an objective measure of neural function from preoperative DTI is combined with intraoperative MRI image obtained after craniotomy. So we have the intraoperative MRI room and updated navigation fused by intraoperative MRI scan. And we fused the preoperative DTI 𝒂𝒂𝒏, which means the motor fibers can be showed in 3 types of the neural fibers. So in case 1, we indicate a navigation based on preoperative pyramidal tract motor function information. Under general anesthesia, tumor resection is advanced while the pyramidal tract is monitored in real time using the newly developed navigation system, 𝑑𝒓𝒐𝒇. So this video shows intraoperative MRI and updated navigation fused with preoperative DTI 𝒂𝒂𝒏. So you can see this red column is the intraoperative MRI, updated MRI scan, and right column is the 𝒂𝒂𝒏, preoperative 𝒂𝒂𝒏. It is good fused, and we have finally removed the tumor. In case 2, we indicate the navigation based on the preoperative arcade fasciculus language function information. Under awake craniotomy, tumor resection is performed while the arcade fasciculus in green is monitored in real time using the newly developed navigation system. So we continue to develop this tool as a medical device. So we introduced from 2013. We can provide this language examination tool for safe surgery all over the world. We call the EMAS, EMR, Interoperative Examination Monitor for Awake Surgery. So when we confirm patient language reaction at the picture naming task in awake craniotomy, there is 2 patterns. If electrical stimulation hit language function area, the patient could not answer, while stimulation hit non-language function, he can answer. This slide is the history how to examine the language function, showing papers and personal computer, and finally our newly developed EMS monitor in TWMU to present examination this monitor. So prototype from 2004, the sales from 2016 May. this video of examination is style. So real-time display of all the information in the same time is recorded. The characteristics, the patient eyes and task, anesthesia, condition, and staff, and microscopic view and surgical navigation system in update with update MRI scan. So here is a video showing the picture, our international EMS task to understand this system. Yes, just time synchronized language function examination too. Yes, so the three important points of the intraoperative language examination and airway craniotomy. So first one is adequate task selection, counting, picture naming, verb generation and reading, etc. And second point is minimal mapping technique and decision making for maximum extirpation to reduce the operation time and reconversion risk. And final point is precise identification of functional area to prevent false positive. So we share this real-time monitoring in OR. All the OR staff understand what is going on in our craniotomy. So here's the last slide, the important concept of EMS and contributions to safe examination, better patient outcome, and operator skill. This means that time synchronized recording of multiple intraoperative parameters in real time. This contributed to the safe examination and precise checking on the consciousness status and performance during language task. And finally, precise identification of the location and time during language examination. This contributes to better patient outcome and operator's skill. So thank you very much for kind attention.
Thank you, Professor Tamura. So you showed cutting edge technologies and facilities in the department, and including the HyperScott is also surprise to us to know about it. So Scott is at least Scott is a highly sophisticated and cutting edge technique. But you showed in this presentation, HyperScott is a more advanced operating theater in your department. Congratulations on your achievement. These techniques, unique operating theater. Also, the IEMS is very important to recording monitor in the operating room and monitoring the patient face and the patient conditions. Of course, in the navigation information is included in the same monitor. It's very important recording system to know to inherit this system to the next generation, of course. Thank you.
Thank you.
Is there any comment from the audience?
So someone is
short. Please give us comment. Thank you.
Thank you, Tamura Sensei. I have a question. You just mentioned that that the use of tractography, DTI tractography, is not very useful for monitoring the upper limb. Is that true, or I misunderstood that?
That your question is it?
You said that using tractography will give some false positive results for upper limb identification.
Yes.
What's the problem in this?
Trouble. We we estimate preoperatively the pyramidal tract for upper limb, but in the operating room, we can find the monitoring with motor upper limb function detected, but in the preoperative DTI scan cannot assist the pyramidal tract really. So we confirm, or we are confidence with the real muscle test or SEP or monitoring for especially the upper limb. Yes, it's from our experience.
So it's better to use intraoperative electric stimulation cortical mapping. Yes.
Yes, or the directly muscle contraction test for up in awake craniotomy. So we sometimes use for the not only the language but also the muscle very serious motor function near the motor functions area. We use the awake craniotomy. Yes.
And the second question is, you have mentioned that you have used the �ＢrainVisa platform. Is that sort of program, or it's kind of application, or it's protocol?
Not protocol, just released from the French 𝒂𝒂𝒂𝒂 institution, but this is free and can use or download from the website, and you can freely use but the condition is MRI T1 MRI volume to T1 MRI scan is essentially needed. So
okay. Thank you so much.
Please view the website. Yes.
Thank you.
Thank you.
Thank you. Thank you. Good question. So next to Dr. Hai Fan. You have
actually I had a similar question to with Dr. 𝒔𝒐 that in glioblastoma surgery that I can see that you have so many tools to assist you identify the functional area with DTI, functional MRI, awake surgery, IONM, intraoperative MRI. And my question is similar, that if there is a contradiction, the difference between the functional MRI, for example, and also the intraoperative neuromonitoring or awake surgery. So what do you rely on in those cases? Or how often the results are different?
Yes, difference. Yes, because we have some many tools or multiple instrument in or very luckily, so we have to use very yes, we have to use very in sophisticated cases, and so yes, I understand your questions, and for example, functional MRI or DTI scan, we cannot use in intraoperatively because these tools can be detected by the high field magnetic fields for intraoperatively. So we use the low Tesla. You mean the 0.4 Tesla intraoperative MRI scan? So we cannot use. So we use the functional MRI information or DTI information using just preoperative scan. So we divided the indication of use case by case, and just our HyperScott project is just under clinical research in Japan. So we have to continue this project, or using this, for example, false negative, or some information, information interoperatively. So we have to manage or concentrate the results of many things. So we have to continue this story. So
Yes.
Yeah, I hope.
Yeah. In my practice, sometimes we found a contradiction between different tools, and at that point we don't know what to do, what we should rely on, because there are so many confounders for like for IONM during surgery and on navigation, so the other things. So it's difficult for me.
Oh, I really complete that case in your institution, or for every institution is not the same conditions. So normally using basically for example, basic neuro monitoring, and awake surgery is very typical, but the essential point of for detecting the muscle or functional in the operation. So we are confident with this basic technique, and yes. So this is my answer now.
Thank you, Professor.
Thank you.
Thank you. Is there any other comment? I just want to give a comment, asking a question. So, in your institute, do you use the HyperScott every day for the surgery?
Oh, yes, because now all HyperScott was destroyed for constructing the new HyperScott. So we now only use the HyperScott for the removal of the glioma.
So every day, or
not every day, every day. So every case. Mainly 2 or 3 cases in a week.
A week.
Yes. Awake surgery is just we counted 1/4 of the all glioma cases. 1/4.
Or another pathology, can you adapt it to this using the Scott?
Yes. If we cannot diagnose the glioma, for example, in other case, the malignant glioma, or some other is for malignant meningioma, or some attempt to some other disorders. So our staff is very
attractive.
Yes, collaborative.
I see. Thank you. I understood.
Yeah, I have one more comment. We also use a HyperScott in the functional neurosurgery. So to use the intraoperative MRI to confirm the lesion in the cerebrotomy, to check it's a very useful and helpful. So I do believe that the HyperScott has a very promising operating theater for any kind of neurosurgical procedures.
Tokyo Women's University is very good university hospital. One of the Japanese, maybe one of the best university hospital. Thank you. Good comment. Thank you. Is there any comment? Thank you.
Tamura Sensei.
Yes.
Tamura Sensei, thank you very much for your excellent talk. Maybe you should visit the Dr. 𝒓𝒐𝒇, who is living in Uzbekistan, Tashkent, and also Dr. Hui in Hanoi. You should visit, please. Or you can invite Dr. Tamura Sensei, please, in the future.
Yes, we definitely invite him.
Yeah, you're welcome anytime in Hanoi.
So Tamura Sensei, just I want to ask, because very fundamental things, because awake surgery itself is very extreme, is less invasive treatment for the patient, I think. But it's quite a complexity. So many, complex surgery. So because many of the institute in Japan, maybe in future, every institute can do very simply. I think that's good for the patient, I think. Do you think any good idea in the future in your brain? More simple, or more, because you will take maybe in a half day or sometimes 1 day for complete surgery, I think.
Yes, we have many experience, but normally many other stuff, for example, anesthesia and operating staff is very very suggestive for, and also our Japanese Society of Awake Surgery is assisted our activities. For example, the insurance, yes, insurance, or the supporting technical system, and is dedicated yes, institution recognition system. So we have already normalized the technique and awake surgery guidelines, and so let us discuss further in the future. And we have also published the awake surgery guideline in the worldwide. So let us confirm or discuss in the future more. It's my opinion.
Maybe in the near future, every institute in Japan, we can do the awake surgery very a simple way, I think. That's very ideal. Thank you very much.
Thank you. Yeah, is there any comment? Question?
Maybe Sharon?
Yeah. Thank you very much. I think thank you very much, Prof. Tamura. Enjoyed your presentation today. So like both like Dilshad and Hui-Pam, I also have a lot of experience, but I mean in awake surgery, but of course you all are so lucky to have a lot of these extra tools to assist you all. So I think for us in the countries where we don't have these tools, a lot of times we have to adapt a lot, and I think build our own sort of protocols and ways to overcome all these little obstacles. But it's great when you can work with a lot of tools. But I believe, like what Prof. Yoko Kato has said, I think the future is that we need to move towards having a complete kind of treatment for our patients. Yes. Thank you very much. Prof. Kimura, you want to say anything? Any closing remarks before I pass to Prof. Kato?
Finally, I just want to additionally a short comment. So awake surgery is a good, of course, good option for the good surgery, especially for the glioma surgery, parenchymal lesion, of course. So, but I hope the shorter surgical time is a simpler surgical procedure, and the limited operating staff is maybe mandatory to, maybe hopefully awaited for the future surgical system in their awake surgery area. So thank you, but excellent presentation. We enjoyed that we learned so much, and yes, enjoyed so much. Thank you. Professor Yoko Kato, please.
Thank you very much we had a very nice 3 talks today in variety topics. I think we learned a lot from 3 speakers. Maybe the next time we will have a more exciting the webinar. Thank you very much for everyone. Good night.
Good night, everyone. Thank you
田村先生、
very
木村先生、ありがとうございました。
どうもお
Thank
疲
you.
れ様でした。
ありがとうございました。
This shot.
ありがとうございました。Thank you. Next
This
time.
shot. Maybe you can invite Tamura sensei, okay?